First of all, I'd like to thank the organizing committee for inviting me to talk on this topic, the angry silence HIV when to suspect. For the next 30 minutes, my task is to talk about the epidemiology of HIV, an overview of the normal immune system, the pathophysiology of HIV, when to suspect HIV in children using the clinical manifestations of HIV based on the WHO classification and the summary. First, the data. For 1984 up to about 2013, we have a total reported cases of 16,516. Of that 16,516, majority of them are asymptomatic. And for AIDS cases, there were reported cases of 1,507. Majority were males. The youth, which is from 15 to 24, is at 4,189. And for children, we have a total of 65. For the mode of transmission, majority of them, at 91%, was because of sexual contact. But for children, it's mostly mother to child, which means that it's from vertical transmission. Some of them had HIV because of sexual transmission. This is for the teenagers. For the overview of the human immune system, what I'd like to do is just give you a brief summary. And presupposing that you have an antigen, the antigen can either be a virus, a parasite, or a bacteria. This will be engulfed by the macrophage, which is the antigen-presenting cell. Ay, sorry, what did I do? Okay, thank you. So the antigen-presenting cell will stimulate the T helper cell. The T helper cell, or the CD4, stimulates the cytotoxic T cell, which will eventually activate the cytotoxic T cell and the memory T cells. When this is activated, the activated cytotoxic T cells, it will be the one which will defend against intracellular pathogens and cancer by binding to and lysing the infected cells or cancer cells. If it also activates the B cell will produce the plasma cells, which will eventually produce the antibodies or the immunoglobulins, and also producing the memory B cells. On second exposure, you now stimulate the memory B cells and the memory T cells. So if your antibodies are produced, they are the ones which will defend against the extracellular pathogens. Now, what happens when you have the HIV? The HIV targets the CD4. Imagine the immune system. Bakit? Asan yung ano ayaw mag- Imagine the immune system being an orchestra, and the CD4 cells is the conductor of the orchestra. So, if the CD4 cell is targeted, you destroy the conductor, and what happens to the immune system becomes haywire. There's no longer a CD4 cell which will activate the cytotoxic T cell, which will supposedly kill the virally infected cells, kill the tumor-making cells. If you target the CD4 cells, there's nothing to activate the B cell, which will eventually produce the immunoglobulins or the antibodies. So there's nothing to protect you from virally infected cells. Meaning to say, you have now bacterial pathogens, intracellular pathogens, extracellular pathogens, and even tumor cells. There are two major classifications currently in use, one using the CDC and the other one using the WHO clinical staging. For the CDC, it makes use of the clinical and immunologic classification. And for the WHO, the clinical staging. For the CDC classification, you have asymptomatic, mildly, moderately, and severely symptomatic. And for the immunologic classification, it makes use of the CD4 cell count and the percentage. Now, let's look briefly at the immunologic classification. The CD4 cell count depends, the normal CD4 count depends on the age group. So for those who are less than 12 months, normally the CD4 count is equal to or more than 1,500. For 1 to 5 years of age, it's more than or equal to 1,000. And for 6 to 12 years, it's more than or equal to 500. If there is severe suppression, usually the number for those who are less than 12 goes down to less than 750 or less than 15%, that's the percentage. For 1 to 5, it's less than 500, again less than 15%. And for 6 to 12 years, it's less than 200. That is approximating the number that you see in the adult age group. Now, why is it important for you to know the CD4 count? If that goes in this level for severe suppression, this is the time that they will present with AIDS-defining diseases. Yung opportunistic infections will come in. Okay, now let's look at the WHO clinical staging of HIV disease in adults, adolescents, and children. So, to the right, these are the staging for children, and for the adults and adolescents, it's a little bit different. No, for clinical stage 1, they are usually asymptomatic, and the only presentation is a persistent generalized lymphadenopathy. For clinical stage 2, they have unexplained persistent hepatosplenomegaly, recurrent or chronic upper respiratory tract infections, namely otitis media, otorrhea, sinusitis, and tonsillitis. They can also present with herpes zoster, lineal gingival erythema, recurrent oral ulceration, papular pruritic eruption, fungal nail infections, extensive molluscum contagiosum, and unexplained persistent parotid enlargement. This is a child who presents with persistent generalized lymphadenopathy. So kita mo dito, puno ng lymphadenopathy yung kanyang leeg. So that is persistent generalized lymphadenopathy. Bakit persistent generalized lymphadenopathy? Bakit yun yung una? Kasi when you have an infection, usually what is targeted is the lymphatic system. So yung lymphatic system mo, so dito yan, so yan yung lumalaki. Ibig sabihin na nag-lymphocyte yung infection mo. They also present with hepatosplenomegaly, and sometimes you have this parotitis, which usually extends beyond what is normal. They can also present with some skin lesions, like for cryptococcal neoformans. And a while ago, you saw the picture of a child who has molluscum contagiosum. This is extensive molluscum contagiosum. So parang tinubuan siya ng muka. And the cutaneous warts. This is presenting with a linear gingival erythema. So ito yung areas na erythematous. And some of them will even present with fungal nail infections. Okay. For clinical stage 3, they will usually present with unexplained moderate malnutrition, which is not adequately responding to standard therapy. Why do they have malnutrition? Because they're frequently sick. They vomit, they have nausea, and they're frequently sick, so wala silang appetite. So may malnutrition. Unexplained persistent diarrhea, which is usually 14 days or more. And sometimes the cause is parasitic in nature, yung mga cryptosporidium, isospora, unexplained persistent fever, intermittent, constant, and it's usually longer than 1 month. They can have persistent oral candidiasis, which usually occurs after the first 6 weeks of life. They can have oral hairy leukoplakia, lymph node TB, pulmonary TB, severe recurrent bacterial pneumonia, acute necrotizing ulcerative gingivitis or periodontitis, unexplained anemia, which is defined as hemoglobin of less than 8, neutropenia of less than 500, and chronic thrombocytopenia of less than 50, all occurring for more than a month. They can also present with symptomatic lymphoid interstitial pneumonitis and chronic HIV-associated lung disease, including bronchiectasis. Please take note that lymphoid interstitial pneumonitis is only seen in children rather than in adults. So this is a child who presents with candidiasis, and this one with orofacial herpes infection, which is usually chronic in nature. This is a child with oral hairy leukoplakia, and this is with acute necrotizing ulcerative gingivitis. This just shows you a picture, an X-ray picture of a child with lymphocytic interstitial pneumonia. Now, for clinical stage 4, usually they present with unexplained severe wasting. So more than 2 ang baba niya from the one that we use. I forgot. Okay. Not responding to standard therapy. They can also present with pneumocystis jirovecii pneumonia, recurrent severe bacterial infections, which includes empyema, pyomyositis, bone or joint infection, meningitis, excluding pneumonia. They can have chronic herpes simplex infection, which can be orolabial or cutaneous of more than a month's duration. Esophageal candidiasis or candidiasis of the trachea, bronchia, or lungs. Extrapulmonary TB, Kaposi sarcoma, CMV, retinitis, the CNS toxoplasmosis, usually after the neonatal period. For CMV infection, it's usually, the age of onset is more than 1 month. HIV encephalopathy, extrapulmonary cryptococcosis, which includes meningitis, disseminated non-tuberculous mycobacterial infection, progressive multifocal leukoencephalopathy, chronic cryptosporidiosis, chronic isosporiasis, disseminated endemic mycosis, lymphoma, which is more common in children than in adults. You also have leiomyosarcoma, which is more common in children than in adults, and HIV-associated nephropathy or cardiomyopathy. So this is a child who presents with chronic herpes simplex infection of the orolabial area. This is a child who presents with pneumocystis jirovecii pneumonia. In some children, they can also present with Kaposi sarcoma. So this is how they will look like. This is a child who has severe wasting, and this one, wasted with encephalopathy. Now, you might think, or maybe you might wonder, why are some children presenting early? And why are some children presenting late? That's because there are some who are called rapid progressors. In 5 to 25% of the time, those infected newborns, usually in the developed countries, may develop AIDS within the first few months of life if they are left untreated. And the usual median survival time is 6 to 9 months. What is seen more commonly in these rapid progressors are opportunistic infections and neurologic complications. And those who are infected intrauterine, with most of them showing positive HIV culture and or detectable viral load with a median of 11,000 copies in the blood, are usually seen in the first 48 hours of life. So these are what you call the rapid progressors. Sometimes they can start with manifestations as early as 4 weeks to 6 weeks of life. What about the long-term non-progressors? So in 5 to 15% of the time, they do not experience clinical or immunologic progression despite long duration of infection in the absence of highly active antiretroviral therapy. Usually, they maintain good CD4 counts. You remember yung CD4 counts? So ang maintenance sila parang normal. And if you look at the viral loads, they have low viral loads. So pag sinabi mong low viral loads, walang masyadong nagfa-fight off with the CD4. So I guess that's the reason why the CD4 is maintained. Kasi mababa lang yung viral load niya. What about the elite controllers? They only constitute less than 1% of children with HIV. They usually maintain undetectable viral loads, which is usually less than 50 copies per ml, in the absence of highly active antiretroviral therapy. This means that they still have the HIV, kaya lang hindi nila ma-detect. Generally, there's very slow disease progression. And in fact, there were some infected for 25 years without signs of AIDS. Now, I will just show you a couple of these studies done in India and one single study done in the Philippines, showing you the common clinical manifestations, the signs, the PE. So this one was done in India, reported in the Indian Journal of Pediatrics. It involved 58 children, majority of them are male, and the mean age is 4 years. For the transmission, it's predominantly perinatal. The most common clinical manifestations are as follows. They have oral candidiasis, they have pulmonary TB, recurrent respiratory infections, bacterial skin infection, papulopruritic dermatitis, hepatosplenomegaly and lymphadenopathy, and chronic diarrhea. Another study showed that the common symptoms, this was 4 years later, looking at 71 children. And again, the mode of transmission is mostly vertical. So the common presentations are persistent fever, persistent cough, loss of appetite, loss of weight, and recurrent diarrhea. So if you just compare the two, halos pareho. And the common signs are also from the same study: hepatomegaly, skin lesions, lymphadenopathy, and severe malnutrition. And the common opportunistic infections are TB, recurrent diarrhea, oral candidiasis, recurrent bacterial pneumonia. In fact, 6 children died during the study, and 4 of them had HIV encephalopathy. For the clinical presentation of infants, this was presented by Dr. Ira Shah. For the early manifestations, you have HIV encephalopathy and opportunistic infection. And they specifically named pneumocystis jirovecii pneumonia, cytomegalovirus, and respiratory viruses, and even bacterial pneumonia. They also presented with recurrent gastrointestinal infections and oral thrush. Lymphadenopathy, splenomegaly, and hepatomegaly are often seen in the first year of life. So this is in infants, so I guess they're rapid progressors. Up to 10% of infants presenting with HIV have severe developmental delay and encephalopathy. In beyond infancy, they presented with growth failure, fever, diarrhea, and secondary infections. Many children presented with mild symptoms like recurrent ear infections with sinusitis, chronic parotitis, chronic otitis media, nail fungal infections, molluscum contagiosum, hepatosplenomegaly, and lymphadenopathy, which actually persist. In older children, they have growth failure. I guess kasi lumaki na sila, and because of frequent illnesses, hindi na sila lumaki. So they have delayed puberty, subtle cognitive dysfunction, systemic manifestations, HIV, cardiomyopathy, and including the adolescents, they can present with idiopathic thrombocytopenic purpura. Now, this is a study done in the Philippines. This involved, there were 92 children who were screened for HIV. And of these 92 children, 44 tested positive for HIV. And there were some which were unknown. Now, the clinical presentations that were presented were as follows. Majority of them presented with cough. And then they had weight loss. And then skin lesions, diarrhea, chronic diarrhea, and oral thrush. For PE findings, most of them had cervical lymphadenopathy. They had oral plaques. They have harsh breath sounds. They have rashes, some maculopapular. They had fever, and even pallor and hepatomegaly. In summary, although the numbers are still low, if you compare that with other countries where there's a dramatic decrease in the incidence of HIV, our numbers are slowly growing. And in fact, in the last 2 years, there was an exponential rise in the number of